All right, we're ready to get started if you guys are.
Hi, Dr. Cockerell. I'm Yasmin. I'll be doing the first slide.
Okay, great.
Okay, so this looks like a punch biopsy. It seems to be an inflammatory condition.
Good, absolutely.
And going in, when I was looking at it a little bit closer, it looks like they're mostly lymphocytes to me.
Yeah, what kind of pattern do you see here with low magnification?
I would say it's nodular and diffuse.
Good, excellent. Yeah, it's very nodular. You can see it's forming these little nodular aggregations here, and it's pretty diffuse. So that's very good. And that's one of the reasons why we really like to get a punch biopsy. If you just had a shave biopsy, you wouldn't be able to assess any of this down here. And I think it's important. You know, this part down here is, there may be some pathologic changes in there that are important to the diagnosis. So good, I agree. I think a lot of them are lymphocytes. It looks to me like some of them are a little paler down here. So there's probably going to be some histiocytes in here also, just at low power. We're going to obviously confirm that as we go to higher magnification, but lymphocytes and histiocytes. So if it's got histiocytes predominating, what do we call that type of inflammation?
Well, I was thinking something infectious.
Well, infectious is one cause of that, but when we see areas where histiocytes predominate, what do we call that? What kind of inflammation do we call that?
I am forgetting.
You probably know, you're just not saying it.
Oh, granulomatous?
Yeah, granulomatous inflammation. And there's several different patterns of granulomatous inflammation. There's, do you remember the 5 patterns of granulomatous inflammation off the top of your head?
I don't.
Anybody want to help her out? Well, there's the first type is suppurative granulomatous dermatitis. And we often do think of infectious diseases when you think of that. Probably the most common of that, though, is ruptured folliculitis, ruptured cyst, palisaded granulomatous dermatitis, granulomannulary, NLD, rheumatoid nodule, those 3 classic ones, and then a few others. Sarcoidal granulomatous dermatitis, looks like sarcoid, obviously. Foreign body granulomatous dermatitis, where you actually can see some foreign body giant cells and things like that in there. And then tuberculoid granulomatous dermatitis, where you get central caseation necrosis. So in different diseases will give you different patterns of granulomatous inflammation. So here, you said there's definitely some granulomatous inflammation. It sort of looks maybe suppurative and granulomatous. I mean, I do agree with you that there are lymphocytes here, but there may be a few neutrophils in here as well. But there is some epidermal hyperplasia, which we often see with that. We get some overlying pseudocarcinomatous hyperplasia. So that's another important point. If you take a shave biopsy of an infectious disease, it's got suppurative granulomatous dermatitis with epithelial hyperplasia, you may get a misdiagnosis of a neoplasm. So that's another important point. So you thought this was an infectious process. Okay. Yeah. Any particular infections that like to give this pattern?
Well, I was looking a little bit closer, and you see these like dots and spores to me, kind of surrounded by like a clear space, and that made me think of histo.
Okay, so you're seeing some little dots here, and there's also quite a few lymphocytes that infiltrate here. There are some neutrophils. So there's a differential diagnosis when we have, what do you call those dots? Where are they located, actually?
They're within the histiocytes, is that
Good,
correct?
they're within the histiocytes. Good. So this is what we would call intrahistiocytic parasitism, if you will, intrahistiocytic organisms. So there's a differential diagnosis of that, correct? So one of them is histoplasmosis, but what are the others that can cause that?
So I know Leishmaniasis.
Good. Leishmaniasis can do it.
I believe rhinoscleroma.
Good. Rhinoscleroma. What disease causes that?
That is, I've forgotten.
It's Klebsiella.
Oh, yes, yes.
Klebsiella, I believe it's granulomatous is the name of that, I believe. They change those names every few years. I sort of refuse to learn the new names, but they do like to change them because they don't have anything better to do, I guess. There's a couple of others, though.
I think there's another Klebsiella infection, granuloma inguinale.
Yeah, have they changed that name to Klebsiella? That used to be Donovaniasis is the other
Oh,
name.
yes, I remember that as well.
But they may have changed that name too, for all I know. But that's the other one to remember. And then there's one last one that's less common, but one that we see in patients with HIV infection from the Far East.
Is it crypto?
No, that's not actually usually intracellular. It's more extracellular crypto.
Mm-hmm.
Penicillium marneffii. They may
Okay.
have changed the name of that too, for all I know, but that's what we used to call it, penicilliosis, and that's often seen in HIV positive patients from Thailand. So the key to this is just getting it into the differential diagnosis. I believe that this one actually, we stained this for GMS and cultured it and everything else, and it did not grow out histo. If you look carefully in this little organism, right, this little cell right here, they're forming a little sort of rim of these little dots at the periphery of that histiocyte right there. And that's known as the marquee sign,
Wow.
or we like to call it here in Dallas, the Ferris wheel sign, because I think it looks like the Texas Star Ferris wheel out there at State Fair of Texas. But that is a finding that's seen more commonly in leishmaniasis. It's actually seen in the New World form of leishmaniasis rather than the Old World form. This isn't the most classic case of leishmaniasis, because I agree with you. It's a little bit, it doesn't show too many of those classic obvious marquee signs. And it shows some cells that, that you could make a case for there maybe being some little almost capsules surround some of these. So I don't think the board examination would give you something like this and expect you just to look at this slide and say, it's leishmaniasis or histo or whatever. They probably would give you a special stain, or they might give you some more information about the slide or something like that. But the most important thing is, number one, recognizing the pattern of inflammation, which you did quite nicely, recognizing that it's probably an infection based on that dense diffuse infiltrate with granulomatous features, remembering the patterns of granulomatous inflammation, because each one of those will give a different type of, different diseases tend to give different patterns there. And then the intrahistiocytic disorders. So this is a good type of slide that they could very well, you'll probably face this on the board somewhere, somehow. So they will probably ask you something about this. So I would know this information. Now, as far as leishmaniasis goes, I would recommend also knowing a little bit about the organisms that most likely cause leishmaniasis, the New World versus the Old World type. So they're not going to ask you probably a lot of questions about that, but you may as well know Leishmania tropicana, mexicana, brasiliensis. Those are the more common New World types. So make sure you know about that, because that's just it's a gimme. You may as well get it right, because they're going to definitely ask you that. So good. Any questions about that one?
Thank you.
You're welcome. This guy gets an A+ for the type of biopsy that they did, by the way. Okay, there's something different here.
Hi, Dr. Cockerell. My name's Yelena. I'll be doing this case.
Great.
All right. So as far as kind of trying to decide what type of biopsy this is, maybe it most aligns with like an enucleation.
Good.
Okay.
Exactly. So whenever you see something that looks like it's kind of like a little cyst or a little marble or something sitting there, there's no epidermis, there's no, it doesn't look like it's really, like the last biopsy was clearly a squared lesion, punch biopsy. This probably, they may have thought it was some kind of a cyst or something. And so they probably took a scalpel and sliced over the top of it and then tried to express it out or tease it out with scissors or with forceps or something like that. So yeah, this is most likely an enucleation biopsy. That's good.
Awesome. And then kind of aligning with that, I didn't really see any epidermis going on here. I see a lot of kind of like non-human like structures.
Okay.
So there's kind of these like exoskeleton looking kind of structures, like outer wall. Yeah. And then there was some like what looks like skeletal muscle with striations.
Good. Excellent.
And then I think those like yellow brown things are like chitin.
Good. That's exactly right. Here's a little bit more over here. What about these structures over here?
I think those are salivary glands.
Yeah, there's some type of gland.
Okay.
I don't know if they make saliva or not, but they certainly make something.
Yeah. And then yeah, just with like the jagged borders, I was thinking it could be like arthropod. It has these like strange, jagged, kind of rigid lines that we don't really see in human tissue.
Good. Excellent. That's exactly right. So yeah, this is an arthropod. And do you know by chance what type of arthropod it is by looking at sort of these little structures, for example?
My best guess was like a maggot larva, like Myiasis.
Yes. So this is well, I call it myiasis, but
Myiasis.
Dr. Rapini, I think, does call it myiasis. I think he says that that's the right pronunciation. He may be right. I don't know. I've always heard it called myiasis, but it's spelled myiasis, but he may be right. It may actually just be myiasis. And so that's exactly right. This is a little fly larva. So tell us a little bit about myiasis. They might actually ask you something about this on the examination. They probably, I don't know, they'd be cruel enough to show you the histology of this, but they might show you a clinical picture and they might ask you a little bit about it.
Well, as far as myiasis goes, my understanding is that it's like when the fly larva kind of bites the skin and kind of puts its like eggs in the skin, and it's kind of in this collection of diseases. There's like tongiasis. I think there's like onychocerciasis as well, like the black fly.
Yeah, that's good. So yeah, they could possibly show you a picture of the organism that causes Tunga penetrans. What does this organism look like grossly, not under the microscope? And what's the most common, what's the one that we have to worry about the most sort of worrisome cause of myiasis in humans?
Isn't it just like maggots? So it looks kind of like a worm?
Well, it's sort of one of these read my mind questions, but they're basically, if you go to, there are these so-called warble flies that then they do bite the host, and then they usually, when they scratch the skin or whatever, then they kind of inoculate the area themselves, and then they get the little eggs kind of burrow down into the skin, and then they germinate there and form this maggot, and then eventually it kind of gets extruded out. And there's one specific organism that's tropic for humans. So it's an anthropomorphic organism, if you will, and I guess anthropophilic is probably better. And that's Dermatobia hominis. So that's the one that you kind of have to be careful of, because that one actually, people are the ones that it likes to bite and then put the maggot into the skin. And so that's more aggressive. The more common ones affect cattle and other animals out on the savannah and this sort of thing, and man is just kind of an accidental host. But there is this one fly that actually likes humans the best. So this, and they actually have these little sort of dark bands, if you will. They're these black little rings, and when you look under the microscope, they have these little sort of yellowish brown chitinous excrescences here, and this would correlate with what you see with the Dermatobia hominis organism. So this is absolutely is an example of myiasis or myiasis, whatever you want to pronounce it. Now, Tunga penetrans, what's the organism that causes that?
Is that the one like for tongiasis?
Yes, that's tungiasis. And what organism causes Tunga penetrans, or tungiasis rather? It's Tunga penetrans. What kind of organism is Tunga penetrans?
I'm not sure.
It's the sand flea. And when you look at it, it kind of looks like a regular flea. I mean, it's got the little arms that are kind of small and sticking out here. It's got the long legs. And people get that in a different way. They actually don't need a fly to inoculate their skin. They're sitting on the beach or they're walking on the sand, and the sand has these organisms in there. And if they sit there for a long period of time or they walk through an infested area, one of them will, kind of burrow into the skin, and then they get this little nodule. And sometimes they actually get underneath the nail. So if you ever walk out on the beach in an area that's infested with sand fleas, you get the sand between your toes and under your nails and all this kind of stuff. Well, if it contains an organism in there, they can penetrate in there and they get a subungual lesion, and it often gets sent into us to rule out a carcinoma or something like that. And they biopsy it, and lo and behold, it shows tongue of penetrans, and it's just basically sitting in there in a little burrow inside the skin. Now they might show you some of these different organisms and expect you to kind of tell them apart. So if you look at a picture of tongue of penetrans, you can see that it really doesn't look anything like this. They might show something like, say, scabies. Would this look anything at all like scabies?
Not really, because with scabies, I picture kind of like the epidermis, and then it has the circular kind of structure where the mite is.
Yeah, it's a small, tiny little lesion. I mean, little organism. It'd be probably maybe this big. It's not anywhere near as large as this. And yes, it's sitting in a small burrow in the epidermis. It's the female mite. You'll often see eggs up there, and sibilla as well. So that's sitting in the cornified layer. This thing is sitting down in the dermis. And sometimes we actually don't get an enucleation biopsy. We get like an excisional biopsy or a punch. Somebody thinks it's a cyst or something, and they just kind of punch out the entire thing. And you'll see this thing sitting in a nice tunnel right there in the dermis, sometimes with inflammation around it, sometimes without much inflammation around it. And then the same thing is true with tongue of penetrans. That's sitting down in the reticular dermis. And there's a couple of other organisms, not necessarily arthropods, but that can cause dermatitic conditions. So what about a non-scabetic mite? Where do those live, and what do they look like? For example, like the trombiculid mites of chiggers, for example, or rabbit mites, or grocer's mites, those things that cheese mites. When they cause a dermatitis, where do they, if you see them, where do they localize in the skin?
I think those are in the dermis as well.
Usually actually in the epidermis, and they actually don't even burrow. So if you're around your dog that's got non-human scabies, mange, for example, those organisms get on your skin and they can cause a dermatitis. But if you biopsy them, they don't actually burrow into the cornified layer and lay their eggs. They don't, your immune system can wipe those out and keep them from actually living in your skin because they're so different. They're totally different species. They're still Sarcoptes scabii, but they're not humans. They're the Canis variant. And so they won't live in your skin, but they can cause a dermatitis. And these non-scabetic mites, they look a little bit almost kind of like rocket ships. If you ever look at them under the microscope, they look different than scabies, and they don't actually burrow into the skin either. They can attach to your hair, if you will. They can get on your skin, cause an itchy rash. And then if you take a piece of Scotch tape, you can see the mites, but they don't actually burrow into your skin. So bone up on your parasites a little bit. They'll ask you a few questions about that. They're very easy to get. I'd personally rather have questions about parasites and infectious diseases than about genetic causes of weird diseases or things like that. So you may as well get these questions right, because they don't take as much time to really learn. But that's good. You're exactly right. That was myiasis or myiasis, however you want to pronounce it.
Thank you.
You're welcome.
Hi, this is V from UT. I'll get this one. We're looking at a punch. At this view, I see lots of muscle in the deeper dermis.
Good.
Some inflammatory infiltrate at the interface, and what actually looks like some clear cell changes in the epidermis.
What part of the body do you think you might be from here?
So I think that's smooth muscle in the deeper dermis, which would place us at the areolar or genital skin.
Yeah, good. Like erectile tissue. That's good. That's
Mhm.
an important clue to the diagnosis here.
Yeah.
You said there's some clear things in the epidermis. That's good.
Mhm.
And
Uh,
what about the shape of the epidermis?
yeah, so I think some areas look a little acanthotic to me.
Good. Yeah, I think it's quite acanthotic. Normally your skin in that area wouldn't be quite this thickened. So I think that those clear cells that you're noticing up there may be related to that in some way.
Mhm. I think the clear cells most likely resemble like hepatoid cells and would point us towards the neoplasm.
Good.
And at this view, you can kind of see that they do. I would start with the pagetoid differential for this one.
Good. Now, this is also, even though this is relatively easy, um, this is just like right down the middle of the fairway for a board examination question. So you're going to see this. So if you can get this right today, that's good. Now they'll probably, it's so obvious here, they're probably going to ask you a differential diagnostic type question, maybe a special stain type of question, maybe is there anything else you should look for kind of question here. So second order question here. So you're right. So this is the so-called pagetoid pattern here. Tell us the differential diagnosis, because it's actually, there's a fair number of diseases that can give you this pattern.
Sure. The three that I was really considering for this one is Paget's or EMPD. But if Paget's with the smooth muscle, it most likely would just be Paget's instead of EMPD. Bowens, melanoma, and I think some other ones would be LYP or Langerhans cell histiocytosis or sebaceous carcinoma. Those are the ones coming to the top of my head.
That's good. You've got 90% of them or more. The other one that can do this on occasion is Merkel cell carcinoma. I believe you mentioned malignant melanoma. I think you said that. That's definitely one. And then there's one or two others. You said Langerhans cell histiocytosis. That's good. There's a condition called pagetoid reticulosis, which is mycosis fungoides, the so-called Warren J. Collop or the Ketron-Goodman form of those diseases, where they can get lymphoid cells in there. Lymphomatous papulosis can do it on occasion. It's less common than mycosis fungoides, but it is possible. So that's pretty much it right there. If you can get those, you're in good shape. Now, you mentioned, and you like which one here the best?
With the location, I would favor Paget's for this one, but if we were to do
I would
any,
too. And notice also, can you see that it actually spares the basal cell layer? It
yeah,
goes right down to it, but it doesn't actually replace it. And see how there's kind of, some people refer to this as the so-called eyeliner sign, where you get these little residual cells at the basal cell layer just beneath the pagetoid cells that are in the epidermis here. So that's a clue that you're dealing with one of the like Bowen's disease, Pagetoid Bowen's, which usually is a full thickness keratinocytic atypia throughout. Here you've got normal keratinocytes interspersed with the cells here, which are actually basically metastasizing into the epidermis. So that's actually how this process is really ongoing here. And this was from the breast in this case. So this was Paget's disease of the breast. And if you wanted to distinguish among those various entities that you mentioned, how would you stain it specifically for this? Obviously, you could put a whole battery of stains on there, but if you want to try to save the healthcare system a couple of bucks, what would be the, say, number 1 or 2 stain that you would put on here that you would say, that proves the diagnosis?
sure. For this one, if I was thinking Paget's, I would favor CK7 over CEA. If I was thinking more melanoma, I could consider like S100. And I guess even if we were to like want to stain the mucin in the cells, we could even consider like Alcian blue or colloidal or iron.
Yeah, or mucicarmine is
mhm.
probably one of the ones. That's an interesting question that you raised, because what kind of mucin is produced by these cells versus mucin that's produced by these cells?
I think it's glycogen for,
Well, it actually does produce a mucin.
oh, I don't know. I don't know.
This is an epithelial mucin, so it's more analogous to the type of mucin that's produced by your salivary glands or your nose when you get a cold, that sort of thing. So that's what we call epithelial mucin, and or sialomucin. It's a little different chemical structure than hyaluronic acid, which is the mucin that's produced, let's say, in a focal cutaneous mucinosis, or the mucin that you see in granulomannulary or something like that, pretibial myxedema. So this is hyaluronic acid, and this is sialomucin. So there's an epithelial mucin, and then there's a non-epithelial mucin. So this would be one that's produced by an epithelial cell. And it actually, as I recall, they used to ask this question on the boards back when I took the boards back in the 1980s. They used to ask which had the lower pH. And I believe that was Jim Graham's favorite question, I think. And it was basically, I believe, the sialomucin has a lower pH than the hyaluronic acid. So not that matters. You don't need to know that anymore. But it's kind of interesting to know that there are two different sources of mucin in the body. One that's from the epithelial cells, like your GI tract, salivary glands, et cetera. And then one that's from the fibroblasts and some mast cells and histiocytes produce that mucin. So this is mammary patch disease. So one final question about this. If you get this and you excise it by Mohs surgery and you get rid of it, is the patient going to live happily ever after, or what do you need to be concerned about there?
You'd have to rule out underlying breast cancer, because it's usually, I think it's like 99% associated with underlying breast cancer versus like EMPDs, like 50%
Yeah.
in a carcinoma.
Absolutely. So in both cases, you want to look for underlying carcinomas. Obviously, if it's extramammary Paget, you're going to look for GI, GU, that sort of thing. But here, it's almost always associated with an underlying intraductal breast carcinoma. So you definitely need to work the patient up more thoroughly. You do mammograms, whatever, and you have to keep looking till you find it. A lot of times they will, even if they just see this, they may do at least a underlying sort of quasi lumpectomy of the area just to try to get out some deeper dermis also, and some glandular tissue, thinking that they may get it. Because a lot of times you don't see any mass down there. It's maybe subclinical in the breast tissue, but it's positive up there in the epidermis. So yeah, it's like a huge red flag for underlying intraductal carcinoma if you have that. So that's good. Great. Very good job on that. So I think you're good to go on that. You don't need to spend a lot more time studying Paget's disease.
Thank you.
All right. Hi, Dr. Cockerell. This is Eugenio or Kenny. I'll take the next one.
Okay, great.
So it looks like we have a punch with, likely a hair-bearing area. There's also hair follicles on this punch in particular.
Yeah, I totally agree. Where do you think it might be?
The neck, or the head and neck region could be an area.
Yeah, I totally agree with you. I think it's a head and neck area. It doesn't have as many sebaceous glands as most face biopsies, but it's possible it could be an area maybe in an individual that just doesn't have a lot of sebaceous glands, and still could be maybe near their face. So yeah, possibly close to the scalp. I mean, some of these are fairly deep, but it's maybe that they're shifted out of antigen. Maybe it is the scalp and they're just kind of shifted into another follicular stage, if you will.
And, kind of one of the most prominent things on low power view is that there are these kind of dilated hair follicles with this almost mucinous-like appearing material right in the center, and a kind of a lymphoid inflammatory infiltrate around these hair follicles.
Okay, good. Is the inflammatory infiltrate only around the follicles?
Well, kind of throughout, but there is some around the follicles as well.
Yeah, I mean, even if you look in here, there's some lymphocytes that are actually within the follicular epithelium.
Yeah, like some follicular tropism as well.
Yeah, there's definitely some of that here. There's some perifollicular, as you noted, but then you've got some within the follicle itself. Now, on a scale of 1 to 10, How dense is that infiltrate, would you say?
About maybe like a 5.
Yeah, I agree. It's not really super dense, so that's kind of helpful. And what were most of the cells?
So I saw, at least for the inflammatory cells, mostly lymphocytes. And I may have seen an EO or two, but
Good, excellent. There were definitely some eosinophils in here also. Not as easy to appreciate on the scan slide, but there are EOs in here also. So what's the pathologic process that we're seeing here?
so probably some mucin kind of deposition within like the hair follicle.
Yeah, and what do we call that?
Follicular mucinosis is one thing you can consider.
Yeah, what else would you consider?
You can also consider follicular tropic MF.
Okay, so the reaction pattern is follicular mucinosis. So that's, but is there anything else you would consider from the reaction pattern perspective? What if you just had this follicle right here? Would you say, that's classic follicular mucinosis here, or would something else come to mind, possibly when this follicle? Sometimes it's hard when you know the answer to kind of go back in time and pretend like you didn't know, and then look at it with a fresh mind and say, well, if I was looking at this for the first time, I know it's follicular mucinosis, but if I didn't know that, what else could this possibly be? And is there anything else this could be other than mucin here?
I guess you'd want to make sure there isn't any other kind of secondary causes of like a follicular plug and the infection, folliculitis.
Yeah, but what about, I mean, if you just saw this without knowing that this was mucin, doesn't it kind of look like spongiosis also?
Yeah.
And so follicular spongiosis is in the differential diagnosis sometimes of follicular mucinosis. Now, obviously we got, this, so we can quickly rule that out. But the point is, if you just see, follicles with some pallor in there and it's really hard to be absolutely 100% sure that this is mucin here. So you might, if you just had this, you might actually stain it. You usually don't need to stain for mucin in my experience. The vast majority of time, you can identify mucin with just routine evaluation. And, we just had this discussion about the mucin with the Paget's disease. What kind of mucin do you think this is? Is this the epithelial mucin or the non-epithelial mucin?
I think this one's more of the epithelial mucin.
Yeah, it is actually. You're precisely correct. So the mucin is actually being produced by the follicles themselves, which is interesting. So what diseases, you've already mentioned one, can give you this histologic reaction pattern? So you mentioned follicular tropic MF. So that's probably the most important one to exclude. But you don't want to call every single one of these follicular tropic MF necessarily, do you?
No. So I was reading that, they divide into like primary and secondary forms. Primary is known as like, alopecia mucinosa or follicular mucinosis. And secondarily would be caused by like, follicular tropic MF.
Yeah, that's exactly right. So, and tell us a little bit about how you tell those apart histologically.
So, and I know it can be a little bit tricky, but I think with follicular tropic MF, you'd see a little more follicular tropism and like kind of lymphoid, like infiltrate around the hair follicle.
I agree. Generally, most cases of follicular tropic MF, you will see some pretty obvious atypical lymphoid cells. It kind of almost looks like mycosis fungoides involving the follicle. And then also, if you look up at the DE junction, you'll often see features of MF up here. So that's very helpful when you're trying to diagnose follicular tropic mycosis fungoides or MF with follicular mucinosis. You look for other features of MF and you look for the atypical lymphoid cells in the follicle. Now, alopecia mucinosa also can give you some epitheliotropism of the lymphoid cells, but they're not usually atypical. And in my experience, you get more eosinophils in that condition, and it's not usually quite as dense of an infiltrate, but that's not always the case. Sometimes it can be pretty dense infiltrate with alopecia mucinosa that's not associated with mycosis fungoides. So it may be tough to tell, but any idea what potential age this patient might be here?
Maybe maybe a little older, just with like the
Well, I was going to hope you would say a little younger, maybe.
younger, because yeah, it can be in kids, and then after that, I was reading those older than 40, and there's like a pincus type.
Yeah, this was, again, I think this was in a young person, but notice there's no sun damage. And if this was on the head and neck area, you'd expect if they're older, there might be some sun damage by this time.
Yeah.
So let's say this was the scalp. What do you think it looked like clinically?
Kind of like a, bald,
Yeah, exactly. There would be alopecia. We got alopecia
Yeah.
mucinosa. It's called that because these follicles are shifted out of catagen, out of anagen, and this may be a catagen follicle here, possibly. In fact, it probably is catagen, early telogen, and then these others are probably little telogen follicles. So these are shifted out of anagen, and they have alopecia there, and so it's an interesting disease. I'm not sure we really know exactly why this happens, but they get the mucin, the inflammation, they get alopecia, and it's usually seen in young individuals. So you don't want to overcall this MF in a kid or in a young person. If you're not sure, you can do T-cell gene rearrangement studies and a few things like that to rule it out. Although interestingly enough, occasionally in patients with alopecia mucinosa without MF, they rarely can sometimes get a gene rearrangement, so it doesn't 100% help you, but it usually does. But most of the time, it's usually a clinical. It's obvious. It's often seen in the eyebrow, like the areas around the scalp. It's a solitary plaque. They don't have any features of MF anywhere else. And then you biopsy that shows this. Now, are there any other situations where you can see this reaction pattern and it's not alopecia mucinosa or follicular tropic MF? You know, the answer to that is yes, but can you tell us a couple of other, and you may not know this because it's relatively uncommon, relatively rare, but there are a few other situations where you can see follicular mucinosis and it's neither of those conditions.
I'm not sure.
Yeah, I'm not surprised because it's fairly uncommon. Sometimes we'll see rosacea can get some follicular mucinosis. We've seen some cases of irritant dermatitis and contact dermatitis rarely can get some follicular mucinosis. So not too many other settings, but not every case of follicular mucinosis is either of those two entities. Sometimes it can occur as a reaction pattern in some other situations. So anyway, that's a good example of that. And this is another case where you can very easily see this on the board examination. If this were MF, what do the lesions usually look like clinically when they have this histologic pattern? This is a good example of showing that right here.
You see like kind of a follicular accentuation or erythema. Yeah,
you get these little follicular papules that they're almost like spines, and they have this cornified layer coming out of the infundibulum like this very commonly. And so the patients with follicular tropic MF will often present with this, almost looks like keratosis pilaris and that sort of thing. And come in, it doesn't look like classic MF, it looks like that. And, maybe you give them some retin A and you kind of blow it off and patient goes along, smolders along for another couple of years. And then finally they come in with obvious plaques or nodules or tumors, and it can cause the diagnosis to be missed for a long time because it doesn't look like classic patch plaque nodular stage MF. It can look more like follicular papules. And, clinicians often miss that diagnosis. So just remember that if you get a patient got a weird case of what you think is maybe keratosis pilaris comes on in an older person and they hadn't had it their whole life, they don't have atopic dermatitis, think about the diagnosis and make sure you take a biopsy because you don't want to miss that. And they kind of come in with a delayed diagnosis.
Okay.
Great. Very good. Okay. So we're showing you some good stuff here that's just kind of classic, straightforward stuff that you can very easily get on the board examination.
Good morning, Dr. Cockerell. My name is Ellie. I'll be doing this one.
Okay.
So we have a shave biopsy. It looks to me like this would be more of an inflammatory process. There's just a little bit of superficial perivascular infiltration. I couldn't really decide.
It's kind of interesting in this condition that we'll talk about in a minute, but Is this condition always seen in inflammatory disorders? Is this pattern we're looking at?
Hmm. I'm gonna think the answer is no.
Leading, it's hard to ask questions that aren't leading questions.
know, I know.
Totally open-ended, but yeah, you're right. The answer is no. We'll talk about that in a moment. So yeah, but this very well could be an inflammatory process also. Absolutely.
Okay.
So what are we seeing here? What's the main?
So I see a lot of spongiosis.
Is that spongiosis?
Or at least a lot of like edema.
Well, there's some pallor
Uh-huh.
within these keratinocytes for sure, right? And then there's also this, what color are we looking at up here?
Pink.
Pink. So
Mhm.
white, pink, and maybe if you look carefully, there's these little almost kind of little granules in there too that are kind of almost pinkish purple. And then you've got this abnormal cornified layer overlying it. It's basket weave, but it's not perfectly normal. It's also got kind of this darkish, basophilic, smudgy appearance to it.
Mhm.
So does that call to mind any reaction pattern?
It does not.
Okay, well, let's see if we can figure it out. So we talk about this is the epidermis.
Mhm.
And when we talk about cells kind of maybe becoming degenerated or breaking apart or maybe exploding, what do we kind of call that phenomenon?
Like necrosis or like
Necrosis is one, and this could be, it's probably a type of, these cells probably are dying in some way or another.
Mhm.
But if something dissolves or it becomes degenerated, if it's not totally necrotic, is there another name for that? How about lysis? The cell is lysing. You know, it's
Uh-huh.
so epidermolytic, epidermolysis here. And what kind of cornified layer changes are we seeing here? Is that normal or is it thickened?
It's definitely thickened.
So what's this reaction called then?
So I was thinking it looked like compact hyperkeratosis in some areas, and orthokeratosis in others.
It's kind of basket weave, but it's not totally, it's hyperkeratotic, but it's kind of basket weave and it's got this kind of abnormal basophilic granular characteristics, which you can imagine be kind of verrucous and kind of crusty and scaly. So this is a good example of epidermolytic hyperkeratosis.
Okay.
So make sure you fix this in your mind. This is a nice example of this pattern. So we talk about epidermal reaction patterns. This is one of about 25 or 30. And so what are some diseases where we see epidermolytic hyperkeratosis like this?
So I was thinking that this could be like an ichthyosis.
It could be an ichthyosis. And which type of ichthyosis do we talk about here?
Like a congenital ichthyosis.
Yes, it would be one of the forms of congenital ichthyoses, probably would develop, you'd see this patient at birth. And what do you think they would look like at birth?
Kind of like a collodion membrane.
They might be collodion membrane. These kids are often born with what looks kind of almost like a very erosive appearance to their skin, because it's sometimes, again, the other name for this is bullous congenital ichthyosiform erythroderma.
Okay.
When they get this, because of all this epidermal lysis that's going on here. And so when they are born, often they look kind of erythrodermic.
Okay.
And then, so that's one, that's kind of an ichthyosis form. What are some other conditions where you can see this histologic reaction pattern?
I'm not sure. I'm sorry.
That's okay. Well, you'll get it. Anybody else know where else we see this reaction pattern?
Can you see it in some epidermal nevi that have?
Yes, you can definitely see it in some epidermal nevi, the so-called Ichthyosis hystrix, or the porcupine man. They get these very thick, large verrucous, eventually the spines that kind of come out of their skin. And when you biopsy them, basically you see this histologic pattern. And it's and when you see kids that have epidermolytic hyperkeratosis and they get older, they start developing these verrucous, very malodorous, crusted areas, often in the, around the popliteal fossa, the antecubital fossa, and they're, they can be anywhere in their skin, but especially over flexural areas and whatnot. And it's a tough disease. So that's basically, when you get epidermal nevi, it's a somatic mutation of the same thing that causes the germline mutation if this occurs in a congenital widespread form. So it's the same genetic defect, and it's a keratin gene mutation. You guys know which keratin gene is associated with this? If you don't, you must learn it, because they'll ask you that for sure. May as well be expecting that. I believe it's a keratin 5 gene mutation, but don't quote me on that. I haven't gone back and read about that in a while, but it's definitely a keratin mutation here. Now, there's a few other situations where you can see this. So those are the two probably most important and most common ones, but there's a couple of other settings where we see this histologic reaction pattern here. Well, they can occur as multiple little small keratoses, disseminated epidermolytic acanthomas. So you say patients coming in, looks like they have a lot of little verrucous papules, warts, or whatever. You biopsy it in the Lohmann hole that shows this. It's been described in rare cases of Grover's disease, this pattern. It's also can be seen as a perineoplastic process. Patients that have that so-called unithost palmoplantar keratoderma, sometimes you biopsy that and it shows this pattern. So just make sure you know this pattern histologically, and then know, a handful of diseases that can be associated with that pattern. Very fair question to ask on the board, and then ask and then about the keratin gene mutation. So this is a very fundamental type of question. So they're going to ask you about epidermal reaction patterns, about focal acantholytic disc keratosis, about this. We just had the pagetoid pattern, spongiosis, ballooning degeneration. So you're going to get questions about that. If I were writing a board examination questions, which I used to do, I would put lots of questions on that, because it's really important to know. And it's something that is straightforward. There's no trick to it. Okay. Let's take a look at this one.
Hi, Dr. Cockerell. My name's Annie. I'll be doing this one.
Okay.
So it looks like we have a shave. From a lower power, I would say it's more of an inflammatory category. It looks like we have just a lot of like these collections of like nodules and diffuse pattern of like inflammatory cells from afar.
Okay. What kind of cells do you think they are from afar?
It's hard to tell from afar. Probably the darker nodules, I would guess lymphocytes, but also
that's really not even that's not a guess. I mean, that's a very educated, smart answer. So these are probably lymphocytes. There may be some other cells admixed in here. You can tell they're not just totally jet black. There may be some cells that may be a little paler. We'll see if we go to higher magnification. But these cells, you can also make a good educated I'm not going to say guess, diagnostic prediction, if you will.
For the lighter cells, kind of like purple, from afar, I would think about histiocytes.
Good, excellent. So we've got a nodular aggregation of cells, have clearly a lot more cytoplasm, probably going to be histiocytes admixed with these little nodular aggregates of lymphocytes and maybe some other cells in there. And it seems to be, if it's a neoplasm, it's a neoplasm of inflammatory cells. If it's an inflammatory process, what pattern do you think it's mostly exhibiting here?
Kind of just a diffuse pattern with like lots of nodules.
Excellent. Very good. Very good. So let's go to higher magnification. Let's take a look. And indeed, at this power now, do we confirm what we saw at low magnification?
We have a lot of the histiocytes, but also like a few like plasma cells and lymphocytes too.
Yes, good. So over here, we've got lots of lymphocytes, so we're right about that. But we can kind of tell even at low power that they weren't totally jet black, and that's because there's a lot of plasma cells that are interspersed here as well. Good. So what kind of histiocytes are these? we have a lot of different kind of histiocytes that we can talk about too, right?
Yeah. So I guess, are you like asking like the pattern of like histiocytic inflammation?
Well, we can get epithelioid histiocytes, we can get Teuton giant cells, we can get Langhans giant cells with multiple nuclei, kind of looking like a horseshoe. You get histiocytes that have asteroid bodies in them and that sort of thing. So these are probably just kind of multi-nucleated, there's several nuclei in here, large histiocytes, sort of not otherwise specified, I would say, but they don't have any characteristics of, say, like a Teuton giant cell we might see in a xanthogranuloma, for example. Is there anything else about these histiocytes that you notice?
Well, some of the histiocytes have like the lymphocytes and the plasma cells in them. So that would be the peripoiesis
Good.
phenomenon.
Superb. Excellent. So what's your diagnosis then?
So we're kind of looking at the histiocytic differential, but since they have the peripoiesis, that's kind of classic for Rosai-Dorfman disease.
Good. Rosai-Dorfman disease. And what's the other name for Rosai-Dorfman disease?
Oh gosh, I think it's like extra sinus. I forget exactly.
Yeah, sinus histiocytosis with massive lymphadenopathy. That's the classic form that occurs in the lymph nodes, but it also can occur in the skin. And there we just don't call it sinus histiocytosis because it's not really sitting in a lymph node sinus. We call it just Rosai-Dorfman disease in the skin. What do these lesions usually look like clinically?
Clinically, if you do have extranodal disease, they're kind of these like, I think they're like red-brown like papules that or like nodules you can see on the skin.
Yeah, they can be like usually a fairly large plaque or nodule. They can sometimes be, they're yellowish often because they've got all these histiocytes in there. And they can be seen on the head and neck area, the groin area. So it's a benign process. Sometimes they rarely have been associated with malignancy, and very rarely do the actual lesions themselves become malignant. So it's one of these things just to recognize histologic. They could easily show you this. If they want to ask you, say, if you wanted to confirm the diagnosis and stain these cells here, the histiocytes, what stain highlights these histiocytes?
And would that be the CD68?
CD68 would highlight them, but they're also highlighted by S100 protein, interestingly enough. So they're probably not, or clearly not Langerhans cells themselves, but they're probably somewhere in the Langerhans cell lineage because they have that S100 protein staining. So this is a nice example of that entity. So I'm glad that you were able to make that diagnosis and pick up on the peripoiesis. These very often do have plasma cells in them. So that's a common finding. They sometimes have a lot of plasma cells, sometimes they just have a few, but this one's a very nice example of that. So this is yet another example of a lesion they could very easily have on the board examination.
Thank you.
You're welcome. This is an interesting one, a little more challenging here. So probably this one less likely to be on the exam, but it's still worth kind of going through it and coming up with a differential diagnosis here.
Hi, my name is Jessica. I can do this one.
Great.
So right off the bat, this looks like an excision. And then looking at it, I didn't see an epidermis. And
yeah, it might be one of these enucleations again. It might have been something deep in the skin, and they said, let's just try to cut this out like a cyst, and surprise, surprise, it's not a cyst.
Yeah, that was another thought, since there was no epidermis, possibly an enucleation. And then just looking at it, it looked like very spindly, so lots of spindle cells. There's some fat cells scattered throughout. Not a ton.
You think neoplasm or inflammatory process?
So I thought neoplasm.
Good. And you said spindle cell. That's good too. Did you think it was benign or malignant?
I thought it was benign.
And why?
I didn't see a lot of like mitoses or like a lot of atypia. And
yeah, good. And this one's going to be a little challenging from pattern, right? Because they just sort of took a big chunk out of something that was obviously probably in the dermis and and tried to shell it out and didn't shell out. So this could be part of something a lot bigger. So suddenly our ability to assess breadth, symmetry, circumscription is sort of out the door. So we have to use the other features, like you said. We have to go down to higher magnification and say, well, is there any atypia of these spindle-shaped cells? Is there any mitotic figures, anything like that? The answer is no. So I agree with you. Now, what are the three most common spindle cells that we see in dermatopathology?
I'm not too sure.
Oh, yes, you are. What's this spindle cell here? And why?
Oh, are you like muscle?
Muscle is one. What's there's a bunch, but the three most common that we have to think about. So muscle cell, smooth muscle cell is one. What's the other one? Or a other one?
Nerve, like neural. So like
Neural, excellent, nerve. And what's this one? The third one.
Like fibroblast.
Yeah, fibroblast. So you did know. There's the three. So just reflex arc. Smooth muscle, you think spindle cell, we think smooth muscle, we think spindle cell, we think fibroblast, fibrohistiocytic. Okay, which one of those three do you think this is?
Maybe neural or
What's this stuff right here?
collagen.
Collagen. So what makes collagen?
Fibroblast.
Yeah. So this is fibroblast, almost for sure. And it's a fibrous lesion, right? There's tons of collagen in this thing. And notice the other thing that you can do. So here's smooth muscle. Here's a blood vessel with the muscle wall. You see those blunt cigar-shaped nuclei here with nice contrast between these cells that are more kind of sharply angulated or plump. So they look different. These look kind of plump, fat, angulated a little bit. These are more blunt-ended like cigars. And if we had a nerve floating in here, we'd see more of those, sort of lazy S type of cells. So these are fibroblasts, and obviously they're making a lot of collagen here. So what's the diagnosis?
So the cigar shape makes me think of like a leiomyoma.
But we're not. But that was just showing the cigar shaped in the blood vessel. So here we're over here in the fibroblast category. So if it's a fibroblast mostly lesion with lots of collagen, call that
a spindle cell lipoma, maybe.
Well, that would be a fat lesion. So remember, we're in the fibrous lesion.
Okay,
here.
maybe a fibrous like histiocytoma.
Okay, well, that's a possibility. I mean, a fibrous histiocytoma is fibroblast and histiocytes, like a dermatofibroma. Clearly, it's got a fibroma component, right? So part of what we just say is just fibroma. Okay.
Okay.
Now, this happens. It's also got some other interesting findings here. It's got this sort of more delicate fibromucinous stroma with these little whorls of fibroblasts. So this is fibroblasts are making, this is probably almost, if you biopsy like a baby and an embryo, if you go in and biopsy an embryo in the woman's uterus still, and you look at those fibroblasts there, they look like this. They look like this sort of jelly-like material. And if you do a intrauterine surgery on a fetus and then they get born, they have no scarring, because if you have this kind of mesenchymal mesenchyme going on there and you damage it, this stuff just recapitulates and doesn't pose any scar tissue. So it's kind of an interesting thing. People are studying to see if we can maybe learn how to produce this in adults, so you do surgery without scar tissue eventually. It's a lot of research is going on about that. So this is what started the lesion. They have these whorls of these, and then they turn into these more prominent fibrotic areas here. And what if I told you this was in a 5-year-old kid or 3-year-old kid? It was a little nodular lesion maybe on the trunk. Any idea what the diagnosis might be?
On the trunk?
Or extremity, for example?
If it was on the extremity, maybe like, I know like infantile digital fibromatosis.
Well, those usually give a little different pattern. They're more, they have these hyaline globules at the tips of these little sort of spindle-shaped cells. Here we've got a lot of these sort of whorls of this more primitive fibromucinous fibroblastic proliferation with these then whorls of thickened collagen forming these little fibrotic areas here. So this is a hamartomatous condition. And if it were in infancy, like a kid, a very young kid, it's a fibrous hamartoma of infancy. So that's what this is. This is an example of that. So basically, but the most important things here are, again, remembering that it's mainly those 3 spindle cells that you need to know, nerve, muscle, and smooth muscle, and fibroblasts, and then histiocytes. And then in this case, you've got the areas of the more primitive fibrous tissue here that's forming these more thickened strands and bundles of collagen here with the fibroblasts. So this is what fibrous hamartoma of infancy looks like. This is a big one. Usually they're not quite this large and they're often not this cellular, but this is a nice example of one of these. So they probably wouldn't show you, they might show you this, but they probably, I don't know, this is a little larger one. They sort of like to show classic examples, and now they can scan slides in. They don't need to get 40 cuts of everything. So they can show smaller biopsies than they used to. Good. So any questions about that? All right, we got through 7. Why don't we save the next one for next time? Any comments, questions, criticisms? Hope you enjoyed the session. Hope you learned something today. And we will see you guys next month.